So hello, everyone. Thank you all for joining us for this webinar, Indian Health 101, Fulfilling a Promise. This is being presented as a part of the National Indian Health Board's celebration of Native American Heritage Month. So over the next hour or so, we may run a little bit short. In that case, I can take questions, but we will be exploring the framework of the Indian health system. So my name is Christopher Chavis. I am a policy analyst here at the National Indian Health Board. So our agenda for today, we will start off by doing a very basic intro to Indian law, some of the underlying principles of Indian law that are important to the Indian health system. And then we're going to start digging a little bit deeper here and going into the legal basis of the Indian health system and some of the laws and statutes to kind of underpin the system. Then we're going to talk about the Indian Health Service and some of the issues that they face and some of the important things to keep in mind about that particular entity. And then we're going to talk about some of the health disparities that American Indians and Alaska Natives face, which will transition into kind of how COVID-19 has impacted our populations. So 5 parts. It is a lot of material, but I think we can get through it well within the hour here and hopefully have a little bit of time for some Q&A. So here's a little known fact. A lot of people don't know that tribes are mentioned in the U.S. Constitution. After all, tribes are the oldest governments in North America. When the first colonists arrived here, they encountered a continent that was already settled by existing sovereign nations. The British government and the Spanish government, they weren't coming into a land that didn't have any pre-existing sovereigns, which is important. It's important to remember, and it's important to know because that obviously kind of frames a lot of the discussions around tribal sovereignty. But I want to draw your attention to Article 1, Section 8, Clause 3 of the U.S. Constitution, which states that the United States Congress shall have the power to regulate commerce with foreign nations and among the several states and with Indian tribes. Now, a little bit of an unresolved question at the beginning of the Republic, though. We know what foreign nations are. We know what the states are. But what is the relationship of Indian tribes vis-a-vis the federal government? And that's going to be a recurring question in the beginning days of the Republic and the subject of 3 very early Supreme Court cases that are kind of collectively known within the Indian law canon as the Marshall Trilogy. So the first one was decided in 1823. It's Johnson v. McIntosh. And kind of a very brief background here. 2 guys bought a plot of land. One bought from a native tribe. The other one bought from the federal government. So we had kind of an unresolved question here of, could tribes sell their land as any other sovereign can, right? We don't dispute the ability of states and foreign nations to sell their land to other folks. But it was an unresolved question at the beginning of the country of, could tribes do that too? So the court held that U.S. Holds this that tribes can only sell their land to the federal government and not to private persons. So again, it's kind of an interesting thought, but it does introduce this it kind of starts to kind of crystallize. As I think we go on, we'll see it start to crystallize even more, but it's the start of the idea that there is a special relationship between tribes and the federal government. In this case right here, I think it's important for kind of kickstarting that discussion. And again, it says here that the United States holds an exclusive right to extinguish the Indian title of occupancy either by purchase or by conquest. So again, you get that kind of idea that that the federal government can purchase this land, and again, obviously that's important later on. But we still don't know exactly what is the relationship between tribes and the federal government. We know that certainly the federal government is, at least according to the Supreme Court, an exclusive customer of tribes when it comes to the ability to take land and buy land. But the question of what is the relationship between tribes and the federal government starts to kind of crystallize a little bit better when we look at Cherokee Nation v. Georgia, which gets into what is the relationship vis-a-vis the tribes and the states and the federal government, and what can each entity do. So this wording right here, I pulled from the majority opinion written by Chief Justice John Marshall. Their relations to the United States resemble that of a ward to his guardian. They look to our government for protection, rely upon its kindness and power, appeal to it for relief to their wants. This is important because this is the first mention in Supreme Court canon of what will later become known as a trust responsibility. It's the idea that the federal government owes it to tribes to provide for needs such as healthcare. So we start to see this language kind of start popping out at us during this era of Supreme Court jurisprudence, and certainly Cherokee Nation v. Georgia is an important one to keep in mind here. The next case we're going to discuss is also important. The open question of what powers do states have over tribal nations was yet to be resolved. So we knew tribes can only sell their land to the federal government. Tribes are sovereign nations, but with an asterisk in the sense that tribes are domestic dependent nations, but we didn't quite know at that point what states could do. So we get Worcester v. Georgia to kind of clarify that. And this case is essentially a criminal jurisdiction case. The heart of the question is, the heart of the question here is, do tribes have criminal jurisdiction, or no, do the states have any criminal jurisdiction on Indian land? Well, the Supreme Court essentially said here, no, states do not have any criminal jurisdiction on Indian land, at least at this point in history. And I underline, I think, the important takeaway for our purposes here. The whole intercourse between the United States and this nation is by our Constitution and laws vested in the government of the United States. So what the court has done here is it has further clarified what the Commerce Clause said. And it said basically, states, you have no part in this. This is not your conversation. This is between the tribes and the federal government. So that's the basis of the trust responsibility as expressed in the US Constitution and early Supreme Court jurisprudence. The other source of the trust responsibilities, treaty obligations. So as the United States marched westward during the period of Manifest Destiny, they signed treaties with tribal nations to acquire the land that they felt they needed in order to expand the country. A part of those treaty negotiations and treaty discussions was the idea that the federal government would provide health care and other provisions to tribal nations in exchange for land and resources. So we have the idea now that the trust responsibility is not just something that has been read into by the Supreme Court, but now it's also written in treaties as well. So that's something that very important to keep in mind. There are multiple sources for this trust responsibility. And it formed a very basic relationship, right? As I said before, in exchange for land and resources, the federal government agreed to provide for the needs of tribes. So here we have kind of a graphic here of ceded land. You can see right around here, 1874 or 1784 rather, the start of the United States. Much of the East Coast had already been colonized by the British. So it's white here, but then you see kind of gradually over time, as we go through the 19th century, just the cessation of land, and taking of land by the United States government. And I'll show you a graphic here. This is based on our analysis of census data, but these are the majority AIAN counties that are still remaining. So these are counties where the majority of the population is AIAN. So you can see here that there has been a widespread loss of Indian land, and in exchange for a lot of that land, tribes were promised that they would have access to health care, that the United States, that the U.S. government, the United States government would provide health care. So the manifestation of that promise is the Indian Health System, which is also known as the ITU system, which stands for IHS, Tribal and Urban. But so you'll see here, these are the statutes that form the legal basis for the trust responsibility. We won't be going through all of them. You could really teach a whole course on just this area alone. It's a very expansive area, but we will go through what I believe to be the most important statutes for understanding the framework that underpins the Indian health system. So the first one is the Snyder Act of 1921. See, here's a picture of Congressman Snyder. He was a congressman from the state of New York. He was the one who introduced this legislation, and it provided for the first time a funding structure for Indian healthcare. So it took a little while for this to happen. 1921 is a pretty substantial time period after the U.S. settlement of the West, but it happened, and it provided that the Bureau of Indian Affairs under the Secretary of the Interior shall direct, supervise, and expend such monies as Congress may from time to time appropriate for the benefit, care, and assistance of Indians throughout the United States. So what we have here is kind of the seed had been planted for what would later become the Indian Health Service. So the Snyder Act provides a mechanism through which Congress could appropriate money for Indian health care. So you may have noted that when Indian health care was first, when the money was first appropriated for it, it was done so under the Snyder Act. It was done under the Department of the Interior. In 1954, the decision was made to move Indian healthcare out of the Department of the Interior and under the Public Health Service, which was under the Department of Health, Education, and Welfare, which would later become the Department of Health and Human Services, where it continues to exist today. So you're starting to see here kind of, you had the Snyder Act of 1921, which provided the mechanism for funding, the Transfer Act of 1954, which provided kind of some of the rudimentary structure that we've kind of come to expect and kind of come to acknowledge today. And I will say, I did see a question in the chat. So this session is being recorded, and we will make the slides available with the recording of the presentation. So you all will have access to this information, and we will share the information out. So the Transfer Act, you start seeing kind of the structure start to form for the modern Indian Health Service. So the next kind of big thing here is the Indian Self-Determination and Education Assistance Act. So to kind of put this in the context of broader federal Indian policy, around the 1970s, you're seeing kind of a sea change in Indian policy. So in the 1950s, we kind of had the era of termination, the era of we don't want tribes to exist anymore as sovereign entities. But then you kind of emerge from that in this era of self-determination, where we kind of, you see the federal government start thinking, okay, well, let's start handing the keys over to tribes, and let's empower tribes to take control of some of these programs. So essentially, this act did that. It allowed tribes to assume control over their healthcare systems. So tribes can enter into what are known as 638 compacts to take control of their healthcare system, and obviously they receive funding from IHS in order to do so. This allows for greater autonomy, allows for the tribes to kind of be creative in how they design their systems. So again, this is important. This right here, remember I said earlier, the ITU system. So up until 1975, we just had we had IHS. 1975 comes along, and now we have the T, right? We have tribal. So, and then, over half of IHS's budget is controlled by tribes under this act. So pretty widely taken advantage of, and tribes have been able to avail themselves of this authority. But obviously some tribes, a lot of tribes have still receive services through IHS. So, this is, huge for increasing the flexibility of tribes and providers to kind of manage their systems in a way that they see as, is culturally appropriate and works for their community. The next item here is the Indian Healthcare Improvement Act, which was initially passed in 1976, and it was permanently reauthorized in the Affordable Care Act. It strengthened the position and the regulatory structure of the Indian health system, and introduced new programs. It really, I think, solidified the structure of the program and reinforced it. It established urban Indian health programs. So again, you have the U, now we have the ITU system. But it also did something else that I think is really important. It permitted reimbursement of IHS and tribal facilities by Medicare and Medicaid. So it opened the door for third-party reimbursement from other federal programs. What it also did, though, is it established the 100% Federal Medical Assistance Percentage, or FMAP. Now, for those of you who don't know what the FMAP is, if you think of Medicaid, it's a state and federal program, and it's structured in such a way that the federal government pays for a portion of it, and which is on the FMAP, and that formula varies by state, and it varies based on also factors, poverty rates, and a few other factors. So it varies by state what the FMAP is. So the 100%. So basically, what the federal government said was states, if there are services that are received through an IHS or tribal facility, the states are held harmless for it. And again, this provision right here, I think it goes back to what I mentioned earlier. When you look at Worcester v. Georgia, it's the idea that states are not a party to this responsibility, that relationship, right? As I said earlier, that relationship exists between the federal government and the tribes. Certainly states do offer assistance. Tribes do partner with states, but primarily it is between the federal government and the tribes. And the 100% FMAP is a great manifestation of that. It's the removal of the state from the equation in terms of financing services that are paid through an IHS or tribal facility. Now, I do want to clarify this. If you are eligible for IHS and you don't go to a IHS or tribal facility, you go to a private practitioner, there's no 100% FMAP there. So it only applies to IHS and tribal facilities. And again, that's that's a recognition of the trust responsibility and the federal government's role in fulfilling it. So I'm going to quote here the Indian Healthcare Improvement Act, which I've cited here, 25 USC section 1602. It is the policy of this nation in fulfillment of its special trust responsibilities and legal obligation to Indians to ensure the highest possible health status for Indians and urban Indians, and to provide all resources necessary to effect that policy. It's a pretty lofty goal, right? Now, the question that we're going to answer or attempt to answer next is, what has the United States done to fulfill this goal? So now let's talk about the Indian Health Service a little bit more in depth. So here's a map right here of IHS regions. So there are 12 regions. So you see they range from, as small as the Navajo region to as large geographically as the Nashville region, which extends from, Louisiana, Arkansas, and Missouri up to Maine. So that is a pretty broad geographic stretch. But so IHS is kind of broken down into regions, which enables IHS to be a little bit more responsive on a local level, and obviously allows them to kind of develop relationships within these communities. So again, you have 12 regions, all of various sizes. You have as big as Nashville and Alaska, and as small as the Navajo. You have California, which is a single state. So again, a lot of diversity in terms of region sizes here. So funding for the Indian Health Service. So despite the trust and treaty obligations, IHS is funded as a discretionary program. So I will give a brief overview of the distinction between discretionary versus mandatory spending. So discretionary spending is optional. Federal government doesn't have to do it. They can choose to do it on a year-to-year basis. Mandatory spending are things like Social Security, Medicaid, and Medicare, right? So those are things that are mandatory items that must be funded every year. Congress really doesn't have much of a choice. So basically the IHS is reliant on yearly appropriations for continued operations. It is also currently only funded at around 56% of need. Although I do want to couch that number and one caveat here. That is a conservative estimate. You'll see estimates that are lower than that in terms of percent of need met. But again, it is objectively underfunded. But the discretionary spending metric kind of leaves it vulnerable to lapses in funding, such as government shutdowns, right? So if there's no funding, the government shuts down. IHS doesn't have access to funding. So certainly something to kind of keep in mind in regards to kind of the funding structure of the Indian Health Service. So I pulled this information here, and once you have access to the slides, you will see here a link you can view it yourself. But according to IHS, here are their funding appropriations. And we'll talk about third-party collections in a second. So you see here between fiscal year 16 and fiscal year 20, an increase of $1.2 billion over that time period, which isn't a substantial increase, but there is kind of an upward trajectory here. The second one that I want to point out is third-party collections. And these numbers are for federal facilities only. So remember, as I said earlier, the tribes do have their own facilities that they run as well. So those numbers are not included here. But you see here an increase in third-party collections over the past few years. So I just got a question here. I'll have to get back to you on how many IHS facilities there are compared to tribal facilities. Off the top of my head, I do know that in terms of hospitals, I think they're about even, but I think there are more tribally run clinics, but I don't have the exact number off the top of my head to provide a precise number for you on that. But I do know in terms of hospitals that I don't think there's much of a difference, but off the top of my head, I don't have the exact number on that. But thank you for asking that question. So let's talk about third-party revenue. As I said earlier, there was an increase in the federal facilities, but what does it look like for the entire system? So in 2019, the Government Accountability Office attempted to answer that question using IHS data. So between fiscal year 13 and 18, third-party collections at IHS and tribal facilities increased by $360 million, right? That's a substantial amount of money. And there are some facilities that report that third-party revenue accounts for 60% or more of their budgets. So third-party revenue is fairly substantial and fairly important. It's on top of the appropriation that you get from IHS. And I do want to note here that IHS is a payer of last resort. So if you go to IHS, they'll bill your private insurer, Medicaid, Medicare, VA, or whatever other payers you have before it comes out of the IHS budget. So it's very important, I think, from that perspective, and this is why enrolling in Medicare, Medicaid, and third-party insurances or private insurance is so important because it does really help contribute money to the system. I do want to highlight that. And there has been, we do have data on this, there has been an increase in Medicaid enrollment for American Indians and Alaska Natives since the passage of the Affordable Care Act. And that's come through at multiple channels. We've seen states expand Medicaid, which expanded the pot and the pool of eligibility for Medicaid. We've also seen some exceptional outreach efforts to kind of get folks into Medicaid and in the private insurance market. So these numbers continue to go up, and it's a reflection, I think, of some of the great outreach that's going on, but also just the fact that states are have expanded and are continuing to expand Medicaid. I believe we're up to 37 or 38 states that have expanded Medicaid, and I think states are still looking into this as an option. So again, third-party revenue is an increasingly important piece of that pie in terms of funding some of these operations. So I do want to talk about per capita spending. IHS expenditures per capita when compared to other federal healthcare expenditures. And I think this piece here, really highlights the disparity in funding that exists. So this is 2015. This is This is obviously for 5-year-old data, but I can tell you that from what I've seen, the number here, 3,136 has gone up, maybe to 4,000, hasn't increased substantially. But again, you look here, actual IHS spending per user, and then you go up to national health spending per capita, you've got less than half. I mean, that's, and then you look over, even compared to Medicaid, it's still, it's better than half, but it's still not quite there. And so you see these disparities with other programs. And I think it really kind of illustrates kind of the struggles that, our people face when it comes to accessing healthcare. So the question here is, what has been the effect of some of these funding shortfalls? And I think we can look at some of these disparities between, AIANs, American Indians and Alaska Natives, and the rest of the population. On average, American Indians and Alaska Natives born today have a life expectancy that is 5.5 years less than the national average, with some communities even experiencing even lower life expectancy. So for example, in South Dakota in 2014, the median age at death for whites was 81, compared to just 58 for American Indians. So again, this kind of highlights, the huge burden that I think a lot of providers, I think, have, in that, you have these huge gaps. And in the next slide here, I will illustrate that even further. When you look at IHS data from 2005 to 2007, again, data is old, but some of these disparities are still there. So, AIAN people die at higher rates than other Americans from alcoholism, diabetes, unintentional injuries, homicide, suicide, cervical cancer, pneumonia, influenza, and maternal deaths. So when you look at, these disparities and kind of how they've manifested themselves over time, you can kind of start to answer that question that I think I posed earlier. Is the federal government honoring what it said, that we are providing the resources necessary to help, and have they been successful in doing that and achieving the goal that they set out? I think the data speaks for itself on that. So the next thing we're going to talk about, I think we talk about health vulnerabilities. I think the natural thing to talk about now is COVID-19, right? I think we all know that COVID-19 is a disease that is made substantially worse by the existence of comorbidities, and is made substantially worse by the existence of these pre-existing conditions. And I do want to point out that, AIAN deaths were disproportionate in a lot of the states that do report ethnicity. And I provided some examples below. And here in New Mexico, AIANs are 51.7% of COVID deaths, but only 10.7% of the population. Montana, 41.5%. And this information, by the way, is as of the end of last month. 41.5% of COVID deaths, but only 8.2% of the population. Wyoming, 28.3% of COVID deaths, but only 3.7% of the population. In Mississippi, AIANs are 2.7% of COVID deaths, but only 0.8% of the population. So you see here that AIAN deaths are disproportionate in many of these 27 states, and these aren't the only ones. Obviously, there are certainly other examples here, and obviously this is all available on our website. As April just mentioned in the chat, you can view this data for yourself at the NIHB COVID-19 resources site, and you can look at other states as well. You can look at your state and see how things are going here. So certainly not a good picture. Disproportionate impact. In July, a data visualization of COVID-19 rates per 100,000 by tribal nation created by UCLA found that if tribes were states, the top 5 infection rates nationwide would all be tribal nations. Now, I want to go back here to impacts on third-party revenue. In a hearing before the House Interior Appropriations Committee on June 11, 2020, IHS Director Rear Admiral Michael Wiyaki stated that third-party collections had plummeted 30 to 80% below last year's collection levels, and that it would likely take years to recoup these losses. So I think a lot of folks kind of remember or know that during the pandemic, a lot of people have put off going to the doctor for a variety of reasons. I think obviously the big one is just the fact that people don't feel safe going to the doctor right now. It's, you have other folks who are sick there. You want to minimize your own exposure to COVID-19. So we've seen third-party collections go down. People also putting off elective procedures, right? Which is obviously having an impact on the ability of facilities to bill and recoup that third-party revenue. So again, the impacts of COVID-19 on the Indian health system, they go beyond just the physical impacts, which are very important. But the long-term health of the system as a whole is obviously imperiled by the decline in third-party revenue, and with this being such a big part of the budgets for tribes. And I'll also mention very briefly as well telehealth, which is something I didn't put in the slide deck, but it is something I work on pretty frequently, because I think the obvious question here is, okay, well, with the advent, and not the advent, but the spreading of telehealth, would that be a way to recoup some of the losses? We've seen telehealth in recent years, it was fairly niche, right? Telehealth wasn't widely used. Now we've seen an explosion of it during COVID-19. I think one of the things that is very important to remember is that tribes are very rural. So it's estimated that 46.1% of American Indians and Alaska Natives live in a rural area, which contrasts with about 20% of the American population. So you have obviously some issues there in terms of infrastructure. We know that rural communities more broadly struggle with broadband. We know more broadly that American Indian and Alaska Native communities struggle with broadband access. So there was an FCC report that came out in 2019 that found that around 46% of rural tribal homes had access to broadband, which is 27% less than similarly situated rural homes, rural people in general. So there is that gap as well. So I do want to make sure I highlight that, because that also impacts obviously revenue and the ability to respond to the pandemic. So I'm going to go ahead and give you all a conclusion to this, and then I'll open the floor for questions and maybe things I didn't address that you all wanted to know, and I'll do my best to answer it. And if I can't answer it, I'll do my best to find you an answer. And just leave me your email address, and I'll try to find an answer for you. But the Indian health system is the manifestation of the trust responsibility that is owed to American Indian and Alaska Native people by the federal government. Whether that trust responsibility comes from treaties, it comes from the U.S. Constitution, it has been enforced by the Supreme Court. I gave you all a quote from the Indian Healthcare Improvement Act. It's been reinforced by statute. The expression of that responsibility is the Indian health system, the IHS, tribal, and urban facilities that are around the country. It faces chronic underfunding and must provide care to an excessively vulnerable population. We have some wonderful folks in the ITU system who are providing exceptional care. And I want to make sure I highlight that. And the effects of this underfunding can be seen in the issues faced by American Indian and Alaska Native people, and some of those disparities that I talked about in health outcomes. So these are, I think, if you take away anything from this, I think these are the three most important things to take away from this presentation, and kind of the broader overview of the Indian healthcare system. This is obviously a very broad overview. Anything I talked about here, you could probably teach a semester-long course on any of the 5 topics I talked about. This is a very complex field, and there's a lot going on, and there's a lot of kind of things to take into consideration. So I do hope that you all, take an interest in this and then read more about it. There's a lot. I think this is a very fascinating area of the law and area of medicine as well. So I will take questions. Here's my contact information. If you don't have a question right now, but you may have a question later, please feel free to reach out to me. I will do my best to respond and answer your questions as best I can. So I will look at the chat and see if there are any questions there that I have not answered, and then I will open the floor. So I did get one question sent privately. Are IHS facilities considered federally qualified health centers or private? So this depends. So there are some tribal FQHCs, and then there are just your normal, I guess, standard IT facilities. So the answer is it depends on the facility, whether they've opted to become an FQHC or not. So it depends on the facility and kind of what they've been able to kind of work out. So the next question that I have in the chat here is, do the CARES Act dollars help offset any of the third-party revenue losses? I want to cautiously say that it does somewhat. Obviously, we've only had two packages that have been passed and signed into law that have kind of helped provide money to providers around the country. Obviously, providers around the country are experiencing issues with funding. So the appropriated dollars have certainly helped, but it hasn't made everyone whole. But that is a good question, and some of the CARES Act funding has been of some help, but it hasn't. And then obviously, to go even deeper there, some of the, think about telehealth a little bit here, in terms of third-party billing and ability to recoup some of those losses. You've seen kind of Medicare kind of be flexible in what they will allow to be billed. So for facilities that can't access telehealth, you've seen reimbursements allowed for a large number of new services. Again, like I said, telehealth kind of went from being this very niche thing to being much more widely adopted. On the Medicaid side, I do want to mention this. On the Medicaid side, it's not federally controlled. So the states have been very expansive. A number of them have been very expansive in what they allow to be billed for telehealth. So you've seen some regulatory burdens kind of lessened during the public health emergency to kind of allow for increased billing for telehealth, which again, as I said, is prohibitive for a lot of communities. But for those who can't access it, you can expand telehealth and bill through Medicare and Medicaid. And we've obviously, if you go to our COVID-19 resource page, we've submitted comments and letters on a number of the Medicare regulations. So we've been quite active in this space as an organization as well. So I will open the floor now. If anyone has any questions, just to keep folks from talking over each other, because I realize now we have a fair number of folks in the conference, and I don't want folks to kind of have that Zoom thing where you're trying to talk and someone else talks. And so if you have questions, just drop them in the chat, and I will read and I will answer them for you all. And if I don't have an answer for you, what I will do is I will just leave me your email address, and I will research that, and I will try to provide an answer for you as soon as I am able to do so. So go ahead, drop those questions in the chat box, and I am happy to answer them. You can also feel free, if you have any questions later, please feel free to send me an email or give me a call. I'm more than happy to have a discussion over the phone or via email regarding these topics. I will say the best way to reach me is probably by email, because it obviously gives me time to research your question, just in case there's something that I don't know and don't have access to off the top of my head. So I have a couple of questions. So the slides will be available after the presentation. We will be sending out, we'll send out the slides. We'll also upload the video of the presentation so folks are able to access it. If you don't receive the slides for whatever reason, please feel free to send me an email. My email is on the screen. Just in case you're not on our mailing list currently, although I encourage everyone here to get on NIHB's mailing list. We send out a wealth of good information, especially in this arena, especially during this time. We have a lot of fantastic information going out. So, but if you don't receive it, please send me an email. I will make sure you have access to the slides. So I did get a question here. Any literature recommendations to get a better understanding of the history of IHS? Yeah, so there are a couple of good academic articles out there on this. Off the top of my head, though, I would say that there's a good article written a couple of years ago by Dr. Donald Warren. I'm trying to remember the exact title of it. I think gave a great overview of the Indian health system. Yeah, I would suggest looking up and Googling history of the Indian health system. Something like that should give you pretty good results. Also, the IHS website has fairly good information about the history of the program as well. So, I mean, it just basically the IHS website does a good job, I think, of breaking down kind of the legislative authorities and history of the program too. So there's a couple of good options out there for getting a kind of a more in-depth understanding of the history of IHS. So I just got another question here. Can you speak to the disease reporting chain for IHS and tribal facilities? Does it go through the state to the CDC, or is there a direct mechanism from IHS to the CDC? That's a good question. I want to say it might depend on the situation. So there's no direct mechanism, but I will say that obviously there may be a sharing agreement between, maybe they may work on an ad hoc basis with the state. But as I said earlier, the states have no role in that relationship between the federal government and the states. So I want to make sure I make that clear. You may have agreements with, you may work with a public health, or a local public health provider or public health service, but there is no direct requirement that you have to do that. So I'll also, another question here. Why do some tribally run clinics choose not to see/pay for referral service for not local tribal members, even if there are patients of that particular clinic? Is this due to lack of funding from IHS? So this will vary depending on the clinic and their reasons for having the different policies in place. Again, there is that flexibility that does exist. The tribes can choose to set their system as they would like to. And then we can talk about referral services. There's also purchase and referred care, which does allow, obviously, for the payment of referral services through IHS, but PRC dollars are incredibly limited. That program is not incredibly well funded, and in terms of meeting the need, in terms of meeting the needs of the referred care. So different facilities have different reasons for their payment policies. I don't want to speak for other facilities and give a broad-based answer, but so this is very much a check your local listings type question. So another question I have here is, have there been attempts to change the IHS funding from annual appropriations to a long-term formula somehow? So there have been discussions about, or advocacy work to kind of change it to a discretionary funding. So there are discussions on that, and there has been some advocacy work done on that. As of right now, obviously, it's still a discretionary appropriation item, but we'll see if that changes in the future. So another question I had here is, can I give an example of the work that we do with health policy and IHS? I'm more than happy to. So and NIHB does a fair amount of advocacy work in the health policy arena. So the work that I do in particular is I draft comment letters on regulations. I draft letters on pending or items that the government is considering doing. So for example, when the CDC issued COVID-19 testing guidance, they revised their testing guidance a couple of months ago. We wrote a letter to kind of express tribal concerns with that. So a lot of it is advocacy and analysis. So for example, when a lot of my work focuses on state Medicaid waivers. So when a state issues a waiver, which they can use to institute work requirements, or they can use to waive retroactive eligibility, or they can use to just pilot something new that they want to try to kind of innovate their healthcare system. I monitor that and obviously conduct an analysis of it. And we work to prepare a comment on pending regulations and voice the concerns of how it may affect the Indian healthcare system. So a lot of it is information and advocacy work, and ensuring that in Indian country has a voice in a lot of these rooms, and that folks are aware of the impacts of some of this legislation and the regulations on Indian country. So, does anyone else have any questions? Okay, I see that. Oh. So I will say, by the way, that I was just reminded that we do have a position open that does a lot of work with direct service tribes and NIHS. I'll also do a plugin that we do currently have some openings on our website. So if you go to our website, nihb.org, you can certainly apply for one of our openings. So I have another question here. IHS hospitals are being closed nationwide, including 2 in New Mexico, which will close emergency/inpatient services during the pandemic. The administration claims that IHS beneficiaries can use PRC dollars to access services at nearby non-IHS facilities, but provides no disclaimers that these PRC services are limited. Does NIHB have an analysis of how often PRC services cover beneficiaries? Off the top of my head, I'm not entirely sure if we have anything recent. I don't know if any of my coworkers who may be on the presentation or in the presentation may know of that. I do know we have looked at that issue, but I don't know if we have any thing in depth that is recent, but it is certainly something that we would want to take a look at. If we do have an analysis on it, it would be on our website. But I'm trying to think if off the top of my head if I know where it would be, or if it's there. But that is a good question. That's something that we certainly do want to take a look at. So next question I have here is, what happens to Indian health if the ACA is overturned by the Supreme Court? Okay, that's a very good question. For folks who may not be aware, the permanent, as I said earlier, the permanent reauthorization of the Indian Healthcare Improvement Act was thrown and was kind of authorized as a part of the Affordable Care Act, right? So if you think about it, the position of the federal government in the Supreme Court case here is we should throw out the entire ACA. So the federal government Justice Department is arguing, let's throw out the entire ACA. There were oral arguments on this, I believe, a few days ago. But one of the things that I do want to highlight here is that in those oral arguments, there seemed to be some openness by Justice Brett Kavanaugh and Chief Justice John Roberts to the idea of the severability doctrine, right? Let's just cut out the part of the ACA that we perceive to be unconstitutional. In this case, it would be the individual mandate, which, as you may recall, I'll go into the weeds on this, was upheld a few years back. I think it was in 2012, under the idea of the individual mandate being a tax. A couple of years ago, some tax reform legislation was passed that kind of zeroed out the individual mandate, right? So you got rid of the tax, which kind of helped give rise to this case rather. So what would, in theory, the ICHEA would be, if they threw out the entire thing, ICHEA would be invalidated and Congress would have to reauthorize it. The other provisions that I mentioned, Snyder Act, the other underlying underpinnings of the system would still remain in some form, but I say that just it would preface that we do have some positive indications from the Supreme Court. Obviously, we don't know which way it's going to go, but that is something to keep an eye on. And I encourage everyone in Indian country to keep an eye on that Supreme Court case, because obviously it will decide in one form or another the future of the Indian Healthcare Improvement Act, which is obviously on the line in that case. So that's a good question. I wish I had a more certain answer, because there's so many ways the court could rule on this. It can either toss the statute entirely, or it can just cut out portions of the statute. So it really depends on which way the court, or the court can just say this is all entirely fine. We don't find any issue with this and uphold the ACA in its entirety. So without going into kind of too long of an explanation, I think I would say keep an eye on it, and keep an eye on which way the court seems to be leaning. A ruling should come out as early as the spring, but it depends on how contentious the decision is and how close the judges are on it. If it's a 9-0 decision, it comes out sooner. Obviously, if it's a 5-4 decision, it comes out later. So it depends on it depends on the internal processes of the Supreme Court. So hopefully that answers your question about that. But I would just say keep an eye on what's going on. We have about 7 minutes left. So I am happy to answer any other questions, or but if I don't have any, I'm also happy to give you guys back 5 minutes of your day here. Okay. So not seeing any more questions. I want to thank you all for taking time out of your day to sit down with us and have this discussion. I think that this is a very important area of law and medicine. It's the intersection of law and medicine in a lot of ways. And I encourage folks, if this kind of work interests you, obviously, you can continue to read deeper. I think April provided a good link to a good article that kind of outlines and includes citations, so you can kind of track a lot of this work. So please do take a look at that. We also have some open positions on our website, NIHB.org. So if you're interested in this, and please go there and read the positions. And then if something stands out to you and you think you're a great fit, please feel free to send us an application. So thank you all for joining us, and I hope everyone has a great rest of their day. Thank you.